Hi, I'm Dave Potenziani. I'm a faculty member in the UNC CHIP program. Welcome to the Health Informatics Seminar. These are weekly gatherings in the fall and spring to explore topics relevant to people who are interested in this field. I'm joined today by several of my students, so you may hear them asking questions later as I look at them meaningfully. The session is being recorded, and that recording will be made available later. If you would, during the presentations, except for the presenter, mute your microphones. But when we come to the Q&A, I will ask if you prefer to unmute your microphone and ask a question, or you may put your question in the chat and I will read it out to the presenters for us to discuss. And now I'll turn it over to Dr. Ed Hammond of Duke University to introduce our speakers.
Thank you very much, David. The topic for today is Health Information Exchange to Health Data Utility, Building North Carolina's Whole Person Data Infrastructure. And we have two speakers for today that will share the presentation. The first is Sam Thompson, who has been the Executive Director of the North Carolina Health Information Exchange Authority since March of 2024. Prior to that, Sam served as the Deputy Director for Program Evaluation of North Carolina Medicaid, where he oversaw quality measurement, data collection, and internal and external program evaluation efforts. He also previously served as a lead evaluator at the North Carolina Division of Public Health. Sam has worked closely with the NC HealthConnex for several years and has championed the use of Health Information Exchange, NC HealthConnex, by NC Medicaid and the healthcare community. The other speaker is well known as well. Dr. Tenenbaum is an associate professor at Duke University. She also is a special advisor for research data innovation in Duke's Office of Research and Innovation. From 2019 to 2024, Dr. Tenenbaum served as Chief Data Officer for North Carolina's Department of Health and Human Services, NCDHHS. She continues to consult with state government, serving as a senior data strategist for NC HealthConnex, North Carolina statewide health information exchange. Nationally, she served as the associate editor for the Journal of Biomedical Informatics, an elected member of AMIA's board of directors, and on the board of scientific counselors for the National Library of Medicine. She also is the new chair of the American College of Medical Informatics, ANSI, and she was recently elected as a fellow of the International Academy of Health Sciences Informatics. Sam, you're first up.
Hey, good afternoon, y'all. Let me get this slide deck up and running. Here we go. I presume if I do this, are you seeing it in presentation mode now?
Yes, we're seeing the presentation mode.
Awesome. Okay, well, thank you for the introduction, Dr. Hammond.
Actually, we're seeing the presentation notes.
You see my presentation notes?
Yeah, we see that split screen, Sam.
That's not what I wanted.
Yeah.
Here, let's try that one more time. If I do it, just this screen, I presume that works a little better, right?
Yep.
All right. So yeah, as Dr. Hammond said, my name is Sam Thompson. I am the Executive Director of the North Carolina Health Information Exchange Authority, and have been for about 18 months now. And I just, because I don't know where y'all are with Health Information Exchange, and I do find sometimes that the folks I most expect to know sort of what a Health Information Exchange is and where they come from don't always. We're going to start with a somewhat remedial stance where we talk about what is a Health Information Exchange, right? So I can go back even a little further than it says on this slide, but a Health Information Exchanges were set up sort of and funded under the Affordable Care Act, which really was in, it started around 2009, 2010. That did a lot to pay for health insurance for people across the country and was implemented largely through CMS. But one of the side benefits of it was it pushed a lot of technology money through CMS and sent it to states to build health information exchanges. And what a health information exchange is an electronic network that gives entities the ability to push information into a centralized hub and pull it out. And so you can see in this illustration that all these different entities, and all of these are represented in North Carolina's Health Information Exchange, can both push in their data, largely in the form of continuity of care documents and admission discharge transfer documents, into the HIE and pull that information out so that they have a longitudinal record on their patients, regardless of where they've been seen. And so we deliver a lot of sort of value to the provider community and the healthcare community more broadly. The major thing, and right, the health information exchange, the core data model is largely at an individual person level. So we take information coming from all these different health systems and sew it together on a single longitudinal record, so that you can, you ostensibly as a provider can go in and see your patient's entire care history, right? And the North Carolina Health Information Exchange was established in 2016, and so our data go back that far. And ostensibly the availability of this information reduces waiting time for patients and staff, and the availability of records. We send out near real-time notifications to providers on if their patients on their panel have had some sort of a healthcare event. We help with medication reconciliation, and hopefully reduce duplicative testing and help close care gaps. So I do like this one. This is all these entities, right? If you look at around the either side of this circle, right, contribute data to HIE. And without us, the situation really does look like the model you see on the left, right? Every entity has, dozens of integrations because they have to connect directly to every other entity, right? And I can tell you from working in organizations where we had care management models that relied on this type of system, that it's incredibly painful, that those integrations go down all the time. They're expensive to stand up. They're hard to regulate in terms of the quality of what's exchanged and where the source of truth is. And so what the Health Information Exchange does is transition from what on the left you might think of as a sort of spaghetti type model to a hub and spoke model, where you have a single aggregator in the middle and all the data is held there, and a single integration with any given entity that can pull all the information they need from that central tool. So when it comes to not HIEs generally, but the North Carolina Health Information Exchange Authority specifically, it was established in 2015 after a few other fits and starts in other under DHHS, and once again under Community Care of North Carolina. It came to the Department of Information Technology, leveraging those dollars based on the Affordable Care Act we talked about earlier, and fell under a public-private partnership that the Department of Information Technology maintains with SAS Institute, the one you're familiar with, the one in Cary. We have a 12-member advisory board that has all kinds of specific healthcare representative roles, a representative from an FQHC, a representative from behavioral health, a representative of healthcare analytics, and so on and so forth. And then we have standing representatives, including the Secretary of DHHS, Secretary of DIT, and the Director of the Enterprise Data Office, as well as the lead administrator of the North Carolina State Health Plan for teachers and state employees. So we do, and this cuts both ways, a good and a bad thing. North Carolina has a mandate to connect to the HIE. So as originally constructed, providers that receive state funds, so that's primarily funds through the state Medicaid program and the state health plan for teachers and state employees, had to connect to the HIE and submit their data. And that deadline was January 1st, 2023. There was a lot of push and pull about that, both about what types of providers would be required and about whether that was a viable model. It leveraged claims from both of those payers. And so if you didn't connect, you would have claims dollars withheld from you. And that was particularly harsh to a Medicaid program that works very hard to maintain a strong network across the state, especially in rural areas where there may be one or two options. So they're very reluctant to have anything that would chase away providers. So some of the teeth have been removed from that mandate, and we're considering where to go from there. But we have very good connectivity. I'll demonstrate that for you in a little bit. So when a provider signs on, they sign a participation agreement that contains a business associate agreement to govern, the safe and secure exchange of data. Then we have a provider outreach team as well as an operations team that actively engages providers in the onboarding process and also engages their EHR in order to make the connection. And that's a lot of work, especially sort of soft work to ensure providers and their EHR vendors remain involved and continue to contribute to the process. And you can find out more about exactly what's mandated and exactly what our data target is on our website, but also demonstrate some of that for you in a little bit. So this is a slide that kind of pulled from a GIS dashboard that illustrates our footprint in terms of primary care. And so you can see across the state, there's the green areas represent places where you're within 30-minute drive of an HIE connected provider. Now, this isn't a weighted map, right? So it might not be the biggest provider in the area. It doesn't demonstrate our penetration in terms of primary cares to which people are assigned, but it does show sort of our spread across the state. You can see that there are a few places in blue where there are providers that are not currently connected but are in queue to connect. Sometimes providers will change EHRs and then they have to go back in line and we have to connect them again. And a few places where we see disconnections, and that could be because the provider went out of business or because, again, they changed EHRs and we have to reconnect them. And then the gray areas are federal areas. So those are, likely military bases, right? You see Fayetteville and down in Jacksonville. And so those are covered by another HIE, the DoD VA HIE, and we connect to them through a different mechanism. We connect to them through eHealth Exchange, right? So this is our national connectivity. So moving outside of North Carolina, we connect to two key national networks. eHealth Exchange, which exchanges data nationally, right? Through largely a federated model. And you can see that all the dark colored states are involved and the blue states are involved in eHealth Exchange. So that gives us national connectivity and can query the HIEs or other similar systems across the country. There's also patient-centered data home that we participate in, and that's a clinical notification system. So if you subscribe to my notifications in case I have a clinical event, and I'm visiting Oregon, my provider in North Carolina will still get that notification because they're in this patient-centered data home network. You might have questions about whether we're connected via TEFCA. That's something I'm not going to get into right now, but would be happy to address. And the short story is not yet. So I always want to assure people that connectivity with us is private and secure, which I would want you to know because most likely most of your data is in our system. So we follow the highest standards as it relates to privacy and security. All our data is encrypted in transit and at rest. We comply with federal and state privacy and security laws, largely governed by HIPAA. And our legislation mandates that data can't be sold or used for profit in any way. Also, as it relates to privacy, North Carolina is an opt-out state, right? That means that unless you actively tell HIE and your provider that you don't want your data to be part of our network, then your data is going to be a part of our network. However, we do everything we can to ensure that you have the opportunity to provide that opt-out, right? So we talk with all our newly onboarded providers about how the opt-out can happen, provide them with materials that they can provide to patients so they know they have the opportunity to opt out. We also provide a great deal of information on that on our website. So there's a few types of connections to HIE, right? And this is the sort of most kind of basic. And this would be for the kind of provider that is basically meeting the bare minimum for the connection mandate. So they're saying, I'll submit my data for state health plan and Medicaid patients to HIE because I have to by law, but I don't want to use any of the tools available through the HIE. And I don't want to submit any patients that are not on one of those two payers, right? So they sign a participation agreement. We integrate them with our system, right? So that our system itself, the HIE is called NC HealthConnex. The entity that oversees it, right, is the one that I work for, the North Carolina Health Information Exchange Authority. So they get integrated and their data push in. We would call these entities filtering entities. We don't have a lot of them, fortunately, but they only send state health plan and Medicaid patients to us. Then we have the type of connection that's typically used by providers that want to be full participants and are, what we would call a full participant, but have maybe less sophisticated EHRs, right? And so those participants have their push looks very similar to the one we just looked at, right? They generate data in their EHR, and that data is sent to NC HealthConnex, right? But then they are not necessarily, most likely not, filtering their patient population. So we're getting all their patients. And then they are taking advantage of our services, right? And we'll go through our service in a second. I've already mentioned that we have a clinical notification service. We also have what we call our clinical portal. That's really something like a read-only EHR. So you can go in and query your patient and see their longitudinal care history across providers. You can see their claims. You can see all sorts of data about them. And so they would do that by logging in via a browser. There's other tools, and we'll talk about them as well. And then there's what we would refer to as a bidirectional connection. So these are typically your larger hospital systems that have a more sophisticated EHR. And with those systems, we integrate with them. They push their data to us, and then they pull their data from us into their EHR. If you're familiar with Epic, you would see HIE data in Care Everywhere, right? And other platforms have similar sort of interoperability interfaces where you can look at data across systems. So what data are we really talking about when we say we have participants submit their data to us? So we have a data target, right? And this is a highly dumbed down version of what we're hoping to see from participants when you see all the little categories, right? And so in dark, we would have what we refer to as patient data. So this is demographic data. So that's their ID, so this medical record number. For claims, it would be their Medicaid ID or their state health plan ID, their name, date of birth, their demographic information. We also have what we would refer to as encounter information. So that would be the characteristics of the encounter that the patient was there for. So things like the date of the visit, the number of the visit, the reason, what type of patient, and so on and so forth. Provider data. Some of the data that we want to see the most and we have to put the most work in to get is this encounter data, because this is largely descriptive of the care someone received in terms of the context of their community. What we also have then in the light blue is what we refer to as clinical data. And this is where we get into your CPT codes and your line codes and things that describe the services people are receiving, right? You can see that across here. the quality of the data that comes in these categories, the data elements, is more variable than I'd like to admit. Obviously, we can't regulate like a payer can to say, if you don't submit your data absolutely correctly, we're not going to pay you. So we do a lot of coaching. We have a lot of provider outreach. We use a lot of tools like, and I think I have some slides on this later, NCQA's data aggregator validation tool, to ensure that the data that we're getting in from participants is usable. And I think there's two kinds of usable here, right? What usable means to a provider, if they're querying me and can use their human eyeballs to kind of discern what the information is they're getting out of the system, even if the values aren't uniform. That's the kind of information that's easily and widely available in HA. When you want machine readable information to do analytics with, that's where we get into all the data quality efforts that I mentioned a little bit of earlier. And if we have time, I can talk about it a little bit later. But I'm going to try and go fast so Jessie has a chance to talk. So this is NC Notify. So I mentioned if you can submit a panel to us of your patients. So this largely happen with primary cares or care management entities. And we will send you notifications when that patient has an admission and discharge or transfer. And you will be able to swoop in, and if you're involved in a value-based payment arrangement, ensure that that patient doesn't get more expensive care than they need and help them get preventive care. And so we can also do that not just by having a panel submitted, but by you simply opting into auto panel management in the HIA, so we can see if you've submitted data on someone before, then we assume they're on your panel. We also have a direct secure messaging tool. So this is really a lot like email, except you can send sensitive data through it. We provide addresses to providers, but providers that are, in their own EHRs or often have their own direct secure message system. So this is, as a lot of tools at HIE are, specifically for smaller, low capacity providers that don't have these big sort of, high octane systems behind them and need something like a direct secure messaging system provided for them for free by the state. So going into more services, we do serve as an integrator for the North Carolina Immunization Registry, which means in standard circumstances, you'd have to go in and manually enter your data. So if you immunized me, then you'd have to go enter it in your EHR. Then you'd have to go enter it again in the NC Immunization Registry. What the HIE does is take the data you've entered in your EHR and push it to directly the immunization registry to try and prevent that double work on behalf of providers. We also do essentially the same thing for electronic lab reporting, right? So we take, for providers that have opted into this, they enter they report their labs data into the EHR, and that passes to disease surveillance systems at the Division of Public Health, as well as NC Detect and other such important tools for public health surveillance in North Carolina. We also have test ordering and results that is a system we set up with the Division of Public Health. And this is literally for getting lab data to the state lab and getting results back. So I don't want to eat up all the time, but this is a roadmap. I can provide a link at the end to all the objectives that the HIA is hoping to accomplish by 2030. Many of them do have to do with what Jessie will elaborate on in her presentation on the health data utility. And I'm going to keep clicking through some key new initiatives for the HIE. This is our clinical viewer, and what you probably can't see very well in the orange box, and Jessie was instrumental in getting this established, is the results of people's health-related social needs screening in the HIE. So you can go in and not just query their health information, but see, their answers on questions related to their any needs related to food, housing, transportation, interpersonal violence. Although I don't think we're posting the interpersonal violence questions. What provider collected that information and how old the data is, and the idea here being that, well, that provider that collected the information may not have been in a place to provide those services. The provider that's seeing you today may be able to, and also to avoid screening people that have just been screened. This one, I don't want to get into a ton of detail here because I could go on for a while, but this was work we did to support the identification of missing people as well as access to clinical data for providers after Hurricane Helene. So we were able to query whether about 27,500 people, mostly on Medicaid, but some actual missing people through Department of Public Safety, to see if they'd had healthcare encounters. And we were able to pull many people off that list and assure, their payers or Department of Public Safety that these people were not in fact missing, but have been located. We also worked hard to get access to our clinical portal to providers working in the affected areas so that they could see their patients' healthcare history, even if those patients were relocated from another area or another state. This one shows our contributions to quality measurement at North Carolina Medicaid, and you can see with using traditional data, just claims and encounters, starting in 2020, the rate for controlling high blood pressure was under 5%, and that's because claims don't usually capture biometric data like blood pressure, right? Starting in 2020, we also ran it again. This was when I was at Medicaid, with clinical data from the HIA, and bumped the rate to 20%. As we continue to better understand the data in the HIA, work with the HIA on better data quality, and connect more entities to the HIA by 2022, you can see that the performance on that quality measure for North Carolina Medicaid bumped to almost 41%. And then again in 2023, bumped to 52.5%. Again, this is not likely a change in clinical care. This is a change in the availability and quality of data that's coming through the Health Information Exchange. This gets into work we're doing with North Carolina Medicaid, and I don't want to go deeply into this, but this is a ton of work related to digital quality measures, which is sort of an integrated, closer to real-time quality measure that capitalizes on claims and clinical data, and can post to providers in real time. If you've ever been involved in any value-based or population health management programs, you know that if you're working with claims, that data can be anywhere from 90 to 180 days old, which really undercuts your ability to close gaps with your patients. And so we can digital quality measures will help with that. We talked a little bit about health-related social needs screening and exchange already. And then we're also taking on a use case related to the exchange of bulk claims and care management data to ensure that patients' continuity of care when they change payers and when they change providers all the data is there to take care of them appropriately. This is another one on Medicaid services, but I am going to hand it over to my colleague, Jessie, so that I don't eat up this whole time.
Thank you, Sam. Both for the excellent presentation and for handing it over to me. And thank you for the shout out on the HRSN. I would say that is one of my proud accomplishments from my time at DHHS. Okay, let me start my slideshow, and inevitably I will probably have to switch the, oh no, look at that. It actually did the right one. So hello, for those who don't know me, I'm Jessie Tenenbaum. I wear many hats, and I'm a little multiple personality here. So this slide shows me wearing my hat for Sam for NCDIT and doing this work with the Health Data Utility. I am also faculty at Duke, as mentioned, and UNC technically. I can't keep track. Okay, so what is a health data utility? Sam talked about what an HIE is, so hopefully you have a really good grasp of that at this point. We describe a health data utility as an HIE on steroids. And so instead of, and actually I failed to say, I have been brought in to consult on creating an HDU in North Carolina, taking the HIE as it is and expanding its scope to become an HDU. So with that, let me explain more about an HDU. It's beyond just clinical data for the sake of clinical care, going to additional types of data like social determinants and justice and education and homelessness data to really be a whole person health approach. This requires a designated authority. As Sam mentioned, the State General Assembly created the HIE authority. And so we're working with them to pass a law that says we are now an HDU. It really has cross-sector cooperative governance. It can't be any one group. And I'll talk a little bit more about stakeholders in a few minutes. It has advanced technical and analytic capabilities, and it supports multi-stakeholder cross-sector needs. So again, not just healthcare, but we want to have a whole person health approach. It's about more than just medical care, but community and population health, intended to help facilitate quality improvement across the system and to help with public health. So this is one of my favorite graphics. And I was joking that I should make it my wallpaper for the number of times I have shown this graphic. In the smallest circle here is your traditional HIE, where hospitals, EDs, and primary care docs share data within an HIE infrastructure. In North Carolina, our state HIE is branded NC HealthConnex, and we really go out into this green shaded area. So today we already have dentistry data, as Sam mentioned, state payer, in particular Medicaid and state health plan. We have specialists exchanging data, we have lab data, local health departments are connected, pharmacies are connected, we have imaging data. As he mentioned, we now have currently just from Duke and UNC as a pilot to bring in that health-related social needs screening data so that patients don't have to answer these really sensitive questions, and then when they see another doctor a week later, answer the same questions again. They can access that data. And they're doing it in a structured way using LOINC standards. And then therapists, North Carolina is actually ahead of many states in terms of the number of behavioral health providers that we have connected and continue to have connect. Where we want to go is this outside most circle, foster care, so child welfare information, community-based organizations like homeless shelters and soup kitchens, first responders, so EMS, housing data, I can move this thing, housing data and homelessness data, schools, which people in this call are, I'm sure, quite familiar with HIPAA. School data is covered under FERPA, which is even more challenging at times. And then justice data, both adult and juvenile. So I really like this diagram for the scope that it shows. I want to make clear, though, that it is not to be interpreted as we throw all of this data into one place and then everyone's got access. It is very much a role-based access. Let me just make sure I covered these cases. So advanced HIE, designated as an authority, we're expanding the different types. Key is to have a lot of stakeholder engagement and input. And we are getting from our stakeholders use cases. We really don't want this to be a if you build it, they will come thing. That would fail miserably. We are trying to understand from stakeholders what are their data related pain points and then try to build a system that's going to help them with that. We're building a shared governance framework among stakeholders. We need to enhance the technical support for the new use cases and data types. A huge part of this is going to be enhanced consent management. So as Sam mentioned today, there's sort of an all or nothing, well, all or nothing for the most part of you either are willing to share your data through the HIE or you're not, with a few additional exceptions for maternal care in particular. And then of course we need a sustainable funding model to keep this going. I mentioned the enhanced consent model. This is not, as I mentioned, that all users will see all data. It depends on your role and it depends on the relationship you have with that person. So first of all, everything I described on the previous slide is A, as allowed by law, B, with the appropriate data use agreements in place, and C, in some cases, explicit consent by a person to say, yes, I want to share this type of data with people at this institution or this role. So here's an example, a clinician, these different colored blocks represent the different types of data. So we have clinical data, social determinants, demographic, public health, social services, and education. A clinician might be able to see all of this data except the education data, which is covered under FERPA. A caseworker might be able to see the stuff on the right side and less the clinical health data. And then CBO staff, that's community-based organization like a food bank or something, might see the social determinants and demographics, social services, but not the education, mostly not the clinical. You can see there's a little carve out here where CBO staff might have access to some of the clinical. And that was based on some use cases we heard from stakeholders where a soup kitchen or food pantry might be making medically tailored food boxes for people, and they need to know if someone has diabetes or liver failure, it's going to affect what they're doing for the boxes. For diagnoses, we had an example where a person was discharged from a hospital and now staying in a homeless shelter. They had a very complicated medication regimen, and they wanted help from the staff of sticking with that medication adherence. But there was no good way to give the staff information they needed to help them. So we want to enable that sort of thing. There's this disclaimer. This is simplified. This is not business rules that we are bound to in the future. We're not flying blind in this, I'm happy to say. Civitas is the national organization for health information exchanges. So you can think of it as like the AMIA for health information exchanges. And Maryland is very advanced in this space and a lot of aspects of health information exchanges. So they partnered together to create this advancing implementation of health data utility models issue brief, and even more helpful, a guide to implementation. So this is sort of the playbook we've been following. It includes 4 phases of developing an HDU. And so you can think of this as it's sort of, so you want to be an HDU, here's what to consider, here's how to do it, here's how to go about it. So there's the assessment phase where you're just finding out what the landscape is, who the players are, what's going on. Planning phase is next, figuring out what we want to do and how we want to do it. Implementation phase of actually doing it. And then sustainability, keeping it going with some enhancements over time. We are here, we have wrapped up the assessment phase and we are entering the planning phase, doing the stakeholder engagement to make sure we don't get too far into the planning without our stakeholders by our side. So who are those stakeholders? On the government side, they are, can I move this out of my way? Maybe sort of, yes. They are obviously the Department of Information Technology, which as Sam described is where the HIE lives, Health and Human Services, Public Instruction, Public Safety, the General Assembly, and the existing advisory board we have. We also have innovation partners, including technology companies and others, as mentioned, SAS. There's a group called the Foundation for Health Leadership and Innovation, and they have been a longtime partner in the context of North Carolina's what's called Healthy Opportunities, which is North Carolina's response to social determinants of health and trying to address those. Unite Us is the company that makes a platform called NC Care 360 that people may have heard of. Find Help is a competitor to Unite Us. There's a whole lot of interesting politics there. And then universities and colleges are good partners for some of the advanced analytic work I mentioned. On the community side, we have community-based organizations like those soup kitchens and homeless shelters I mentioned, social workers, case managers, community health workers, a lot of people on the ground working with individuals. And then at the health system level, we have providers and payers and patients. And there. So I mentioned we need to do more with consent. What are the minimum requirements here? At the very minimum, we need to enable people to allow or block sharing outside of healthcare. And at the minimum, this would be one switch that lets people opt in or opt out. So that's over here. Got that there. We need to enable them to change their mind anytime. So to be able to easily access that, whether it's through a portal or an app or a form. And this is all allowed using today's consent that this could be allowed using today's consent for doctors and hospitals to give treatment. You can include those options. At the other end of the spectrum, instead of just all yes, no, these are, thanks to ChatGPT, this was, please draw a picture of the incredibly granular, complex consent system you might have if you had a bunch of different things. Don't pay too much attention to the actual content because it's a little garbled and ChatGPT-ish, but this is obviously too complex and we don't want to present this level of detailed options to people. This would be fairly unusable. So the trick will be finding a sweet spot that enables people to pick what they want to share, with whom, and to change that at any time, but not make it too granular, but make it granular enough that they feel like they have the control. This is obviously the technology aspect. There's a huge aspect of trust. And so this is why it's going to take a long time. We're building relationships with stakeholders, the ones I mentioned, and groups that represent patients and historically marginalized populations, especially. So on the front end, we need the ability to capture consent in different ways. We need the ability to look over those preferences and understand them easily. And we need the ability to enable guardians and minors and people with disabilities or limited English to be able to access their information. That's all on the front end. On the back end, this is going to require a central consent registry, data tagging for sensitivity. and a real-time engine that's going to check and make sure that data being shared is not going against any of those preferences. We are collaborating with a number of interesting and really exciting initiatives in North Carolina. This one is called Familiar Faces in Wake County. Familiar Faces is a much friendlier version of what people sometimes refer to as frequent flyers. People in the community who have a lot of interactions with the jail and prison system, crisis services, EMS, homeless shelters, and they get stuck in this cycle of having interactions with all of those. It's very expensive, it's very unpleasant, and it's very inefficient. Familiar Faces is working on breaking down those silos, getting better coordination between those entities, and hopefully getting the people out of those cycles. So their mission is coordinated care. Their approach is convening county government, health systems, CBOs, and residents with lived experience to design these human-centered pilots. Hopefully this will cut crisis encounters, improve outcomes, and reinvest savings in prevention. And this is really well aligned with us in that there's already providers and patients' data who are mandated to be connected to the HIE. We can take advantage of that because there's significant overlap with that population. And then ideally, when we succeed with Wake County there, that becomes a blueprint for expanding that further across the state. There are a number of sticky legal wickets for this, and we are partnering with UNC School of Government experts to explore some of these issues. These are things like what state laws apply to the different data types. As I mentioned, well, there's state laws and then there's federal laws applying to the different data types, FERPA and HIPAA most notably. Do these state and federal laws align? They don't always, and so figuring out what to do when they don't. How do we share sensitive information with non-HIPAA covered entities? That's going to be one of the trickiest parts. It's challenging though HIPAA is, it's relatively easy if you've got covered entities or business associates agreements. But when you have your CBOs who have staff that are just volunteers, maybe they're a college kid or maybe they're a retired person who comes in once a week, how do you make sure that they have the appropriate training and understanding to keep data secure? And then what consent forms or agreement must be in place, as I described above. We also want to demonstrate return on investment here. And so we're working with researchers in Fuqua and Stanford to both qualify and quantify how does this align with interests across stakeholders and what are their benefits and value propositions. This is the actual ROI is going to be dependent both on the benefits and value propositions they get and the cost of implementation and operations, and figuring out a sustainable funding and business model moving forward. There's a number of other states. I just want to check on time. Okay. There's a number of other states working on this as well. That's been another very useful thing. Besides Maryland, there's a lot of states doing parts of this. And so we both look at what they do and often talk to them to say, how did you do this? How did you get around this obstacle? So some of the funding may come from Medicaid. Some of it is time-limited grants. The continuous funding, you sometimes have hospital rate assessments baked into it or participant subscription fees, state contracts for public health, and sometimes payers may contribute. I'm going to skip over some of this. I want to make sure we have some time for discussion. Here's just some success stories. As I mentioned, Maryland is relatively advanced in this. They deliver real-time infectious disease alerts from their Department of Health to EDs and providers before contact tracing even begins, which can enable faster isolation protocols and clinical response. You might think, well, that sounds very healthy. Isn't that just an HIE thing? Some states, or actually many states, the division between clinical data and public health is extreme. That was one of the things that surprised me most when I was at DHHS. In California, they have their data exchange framework. One of the most compelling things about this is one agreement that all the providers across California sign. So this is not so much a centralized repository, but this data use agreement and rules of the road for everyone to follow. And then New York has, in Bronx, they have this Rio where they implemented a reporting tool called the Face Sheet for CBO members, so that if someone is new in a shelter or in a food kitchen or something, they can pull a lot of the information about the client from the HIE to streamline that client intake so they don't have to fill out again their name, their phone number, their address, etc. Some of the key use cases that we have identified, one is actually, it came from Duke. Jeannie McPeak-Hins mentioned the providers just want to know if they have a patient who screens positive for food scarcity, is that patient enrolled in SNAP or not? Because if they're enrolled in SNAP, great, they're going to focus on other things. If they're not enrolled in SNAP, they want to direct them in the right place to enroll in that. Another is WIC renewal. So WIC is the Women, Infant, and Children Nutritional Program, and it is meant for women and children, as the name would suggest, of low income. It can be extended over multiple years, but each time you extend it, it requires getting the child's height and weight and hemoglobin level. That is often captured through a pediatrician's visit. And so if they can get that data from the EHR, it prevents the parent from having to take off work, get into the WIC office, get that separate visit. So those are two of the specific ones. A few others that have come up. One is with pediatric autism providers. Once they give a diagnosis, a child is eligible for a number of different services. Some of those services may be provided in the healthcare context, but some of those services are done at school. And once the diagnosis is done, the provider has no way of knowing whether the child has gotten those services they're eligible for. So we want to enable them to access some of the records from school to just see what services the child has been given. Care managers touch patients at many different levels, and there's not a great system for even knowing who the other care managers are, let alone understanding what's been done with the patient. School nurses would very much like to be able to see some of the medical information for context. And then I'm going to skip the last one. It's a kind of unique edge case. So next steps for this work, we're going to convene an advisory board. We're finalizing the governance structure. We're refining and finalizing those priority use cases that we want to start to build from the start. Performing the legal analysis, as I mentioned, with UNC. We need to secure funding both for that initial upfront investment and then ongoing, and continue the stakeholder engagement. That's going to be key to building relationships, building trust, and making this succeed. That is all for me for now, and I think we have some time left to take questions. I will stop sharing now.
Thank you both very much. I do ask if you would like to pose your question live, just unmute yourself, raise your hand, and I can call on you. But while you're thinking about doing that, let me start with a few questions that came in on the chat. One was, I would imagine the quality and consistency of data varies across the network. This is an old IT issue. Are you evaluating the clinical value of the network? What is the use of data between or in another institution or between institutions? And Sam, Jessie, whoever wants to
I can speak to this.
The same question.
Yeah. So, we're definitely evaluating the quality of the data. I want to separate because I think it's two questions. What is the quality of the data? Are we evaluating it? And then are we evaluating the utility of the data as delivered to providers? So I think for the latter question is easier to answer, which is yes, but not at the depth I'd like us to. I think when we survey our users, we usually do it by tool, and we find, especially for sort of our, highly used tools like our clinical portal, or Notify, that providers say, that the data they get informs them in the care they provide to their patients. Let me see if I can pull this up actually really quick. So here's a couple sort of survey questions from a recent one on the clinical portal. Share. So you guys see that? So this is, I can usually find what I'm looking for, which is a major data quality. Can you find your patient? Can you find their information? Right. And we do see, we're loading up at, over 70% of providers saying yes. I think the problem with some of these is that we don't have actual providers responding to them. A lot of time our points of contact are technology people, and they may or may not be the system using the tool. And I think where the rubber meets the road on this is, does the information that they access help them provide more informed care to their patients? And here, we see loading up at even, higher, above 70% saying yes. So we feel fairly confident with outreach like that, that the data is valuable. I think there's more in-depth work to be done that we're, attempting to do in terms of partnering with providers to get qualitative and quantitative data on how the HIA specifically impacts people's health. I think in terms of evaluating the quality of data, like it's yes. There's a lot of what we spend our time doing, both in terms of ensuring that at an initial point of connection, when we integrate a new provider, are they hitting our data quality targets? Are they meeting certain standards? We also do sort of retrospective evaluation using the National Committee for Quality Assurance's data aggregator validation program that looks really at, is the data that's coming out of the HIE the exact same as when it was entered via provider at the point of care, and sort of validates the data from the source to ensure that it's not getting garbled. We also do exploratory data analysis to make sure that key data elements are coming in from providers and coaching them up on how to submit data better when they're not hitting those targets. The nature of the way the HIE has evolved, and this is the last thing I'll say, is that when we first started, well before I was on, the pressure was to just more integrations, more providers, boom, 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 get them connected. And slowly over time, that balance has tilted towards don't connect them and the data is not high enough quality. So that it's diverse. And the further you go back, and unfortunately for some of the larger systems, they were some of the ones we connected first, they wouldn't meet our current data quality standards. And so we are going back with many of them and kind of working through what it's going to take to hit our data quality standards now and bringing them up to that level.
Okay.
And I can see the next couple of questions, which are probably Jessie questions. So if it's okay, I'll just go ahead and jump into those.
Yeah, so one person thought you would answer this, but it is worth it to take a revisit this. What's the interface or the connection with NC Care 360, and discuss in the Civitas HIE network seems to be pretty direct about the importance of CBOs being involved in governance. Where is the CBO role in NC HealthConnex?
Yes, so Lloyd, I think I did address the second of those two questions, in that it's extremely important, and we've done a lot of stakeholder outreach, and we've been talking with multiple different CBOs to try to make sure their perspectives are there. It's challenging because CBOs go everywhere from like a closet in a church where a retired person hands out coats to extremely sophisticated organizations with their own IT shops. So one CBO is not like another, but we are working to engage people across that spectrum. And then the first one, what is the interface connection with NC Care 360? I'm so glad you asked. We are trying to get them to exchange data with the HIE, not just the SDOH screening data, but also the referral data. We're also trying to get that data to flow from Find Help. And we're trying to get them both to work with us. Lloyd, I'd be happy to talk with you offline about this. But yeah, so that's to answer that. Jessie asked, could you offer the option? Yeah, the idea of giving more or less granularity to people in consent based on their preferences and their savviness. That's a good idea. It's something we should definitely consider as we are figuring out what to do. Lloyd is right. I answered that one. Ed asks, are you doing any analysis of impact of opt-outs on analytics? Sam, I think that's a you question.
Yeah, and I want to pour a little cold water on opt-out, because we explore it and it's massively expensive, right? In terms of participant facing or patient facing, provider facing, health plan facing, and how do we integrate all that data? How do we create an interface that allows for that sort of configurability Jessie's discussing? And what I want to do is put a plug in for your relationship with the North Carolina General Assembly, because the massive cuts that happened to Medicaid, we're downstream of those. And so the things we're excited about doing depend to some degree on CMS and Medicaid funding. And if things are as tight as they are, doing ambitious things like building sophisticated consent tools won't happen anytime soon because of the amount of lift, the amount of development, and then the soft work to get providers engaged in that. So then regarding provider opt-out or patient opt-out rather, I think we haven't looked at it, but the volume of opt-out is so low, I doubt it would majorly affect our analytics, right? And I think we see that characterized by the representativeness of our findings on things like the quality measure results I showed at some point in my slide. So I think we can implicitly infer, right, that it's not having a major impact. I think the major what's impacting our analytics is much more data quality issues in some instances, and then the completeness of our network. And I think it's much more data quality than the completeness of our network. I think the downside of that coin is that probably not as many people, this is just for all friends here, not as many people are aware of and opting out as probably would if it was totally transparent and easy to do. We do everything we can to make it totally transparent and easy to do. We train every provider when it comes on how the opt-out process works, and that they bear the responsibility of making the patients aware that they can opt out. But just given that I sign all the opt-outs, so I see them come past my desk, and there's not as many as I would suspect. So this is also the flip side of consent, right? You should, if you're not consenting, what are you doing? You're opting out, right? So we should have a better consent tool would be a better opt-out tool, and that's what really need.
And
We've got,
I think that was
I'm
all
sorry,
that was all the questions I saw. I do want to just mention, it's been really interesting to talk with people at Duke, which is where I happen to be housed, and talking to some people who are like, wait, what? This exists? That would be so helpful for me. And it's happened a bunch recently. So, if you're talking to a provider, let them know this exists and make sure that they're aware of it if it's going to help their system. It's along the lines of care everywhere, but for non-Epic shops, it's a lifesaver. Or a trouble saver.
We have a question right here.
Oh, was there another question?
Yes.
Will any of this data be used for training of LLMs, or would that be an additional consent component?
No, it would. And we're looking at the primary use case right now is we have no minutes, but I'll try and be very brief. North Carolina, the governor made an announcement today is trying to really invest, especially within state government, in the use of AI. And one of the things that's being stood up in the Department of Information Technology is an AI accelerator, which allows for the proposal of use cases and the piloting of those projects. One thing that would be really useful in the HIE is that, we talk to providers, some of you are probably providers, and they say man, this is a cool tool. There's so much in it. I do not have the time to dig through patients' records to find the thing I need to know, given how much time I have a day and how much of it I need to spend caring for my patients. And that ignores the fact that a lot of our users are care managers and social workers that wrap around that provider to give them information. But even still, all those people have difficulty making sense of the HIE, also the data quality degrades, the ability to find things quickly. So what we've seen proof of concepts for are overlays for tools like our clinical viewer that can do things like surface the top 3 things a provider should be concerned about if they're seeing this patient today, as well as sort of a smart search tool that can, sum up a lot of our data as clinical notes and free text that can use, so you can ask it a question just like you would any AI, and to get, what's this person's immunization history? Do they have any labs related to that, their last several pregnancies, whatever it might be, and that it will dig through things and come up with that information, because as a human, that would be very difficult to do, or as a normal search tool. So we will be hopefully piloting that soon. Some of it is dependent on the generation of synthetic data, because we hold very sensitive data, and we can't use that in an AI pilot, at least not yet. There's the kind of wraparound security isn't available. So that's what we're aiming for. And I think that would be a huge difference maker in the usability of our tool.
All right. I have questions, but I'm not going to ask them because we're out of time. I thank everyone for attending, and this has been really quite interesting. Having worked in this field 15 years ago, it's nice to see something actually come to fruition that was just a fever dream at that time. Thank you,
Thanks so much,
everyone,
Dave.
for participating, and come back next week and we'll learn more.
Bye, all. Thank you.
Bye.